Hey, you all, welcome back. My name is Lourdes. If you are new here, I help people and you pass the NCMHCE with purpose. Today, we're going to be diving into personality disorders, where patterns of thinking and behaving become so fixed they start to feel like someone's whole personality. Before we jump in, I want you to listen for one key phrase: egocentric. That means the person or the individual does not see a problem. Their behavior feels normal to them. And I also want you to remember this: personality disorders is not about labeling people, it's about understanding patterns. So, as therapists, we can treat them compassionately and ethically. Also, quick update: we just hit 500 subscribers, and I appreciate each and every one of you. Like, you guys don't understand. I work a full-time administrative job. I'm an assistant principal. I also tutor students on a weekend, and I also record content. So your support has shown me the real power of consistency. Also, I just want you to know I finally submitted all of my documents for licensures. I was missing my CEUs. Guess what? I sat down one day, I took a day off from work, and I completed them. Everything is submitted. So any day now, the state should be issuing my certification. I share this because I want you to see that we are growing together. You're preparing for your exam, and I'm stepping into my next season too. So this is just a reminder: it is never late to finish what you started. Also, this January, I'm launching NCMHCE intensives, 4 Saturdays a month, 2 hours each session. We'll go deep into the clinical method. I know some of you guys are commenting on my clinical method video and y'all asking for the narratives, and I never posted it because I'm a little bit sensitive about it, but now I'm going to be sharing it in my intensive. So if you want those, join my intensives. We're going to go deep into the clinical method. We're going to go deep into the DSM, and you'll get access to all my resources. Plus, I also have a private group where you will have assigned homework and weekly discussion with your cohort mates. So if you are interested in joining January cohorts or any cohort before your exam, the link will be in my bio and on my Gumroad store. Lastly, the full personality disorder PowerPoint is available to download on my Buy Me a Coffee page. A small donation, if you fancy, is totally optional. It helps support this channel and allows me to bless another student with a free session. You can also grab the mini narratives on personality disorders on Gumroad. I do the mini narratives because those help you build your basic recall first, and that is foundational knowledge. And if you have your foundational knowledge solid, then you can move on to my full clinical method narratives to help sharpen your clinical reasoning and thinking and skills. Okay, because when you take the test, they have a lot of questions that are easy questions where you're like, okay, this individual will have this disorder, so I know that for this particular disorder, this is the assessment we're used, this is the differential. I like to say those are the questions that you don't want to leave on the table. Those are extra points. So if you have your foundational knowledge, this is going to help you. This is the difference between being 5 points short or being 5 or more points towards meeting your goal. Let's jump into it. Personality disorders are enduring patterns. They are long-term ways of thinking, feeling, and relating that goes against what a person cultural expect. They show up in 4 domains: how people think, cognition, how they feel, affectivity, how they relate, their interpersonal functioning skills, and how they control their impulses. Okay, it is rigid, persistent, and causing problems at work. If they have that, where they have issues at work, home, or in their workplace, in their relationship, it is a disorder. It's not just a quirk. They usually start showing up in adolescence or early adulthood, and they stick around usually without treatment. So the DSM grouped them into 3 clusters, and for the test, it's not necessary to know the different clusters, but I feel like it's important for you to know them by clusters because it organizes your studying in your brain. because your cluster A personality disorders are paranoid, schizoid, and schizotypal. Those are your odd and eccentric groups, right? These are the reference I can think of is like Wednesday Addams or Daria from the Dario show that used to be on MTV. Cluster B is my favorite, my personal favorite. And I'm going to tell you why. Because cluster B are your antisocial, borderline, histrionic, narcissistic personality disorders. They are dramatic, emotional, erratic. These are the ones reality TV producers love. And baby, I love me a good Real Housewives franchise, honey. Okay. And this is why I like cluster B. They like really dramatic. Then we have cluster C. Those are the anxious, fearful, the perfectionists, and the people pleasers. Okay, those are your Sheldon Cooper, Monica Geller. Those are the ones that have avoidant or dependent or obsessive compulsive personality disorders. So I want you to remember that each cluster has its own emotional flavor. We're going to break them down one by one, and when we break them down, you will be able to see and assess how it will show up in a particular client population. All right, so let's get into the first one. We are in cluster A, our odd and our eccentric personality disorders. So for this one, we're going to talk about paranoid personality disorder, PPD. This one is about distrust. These clients believe everyone's motive are shady. They're the I'm not paranoid, I'm just a little careful folks. Those are those individuals. So when you do therapy with them, you want to focus on reality testing and helping them separate facts from assumptions. You have to keep your tone neutral and consistent, and any hint of secrecy can fuel suspicion. They're rarely hospitalized unless they become dangerous. So if you watch the X-Files, think about Fox Mulder. He was always suspicious of everyone. Okay? These are the people are out to harm me types of individuals. Next, we have schizoid personality disorder. They are emotionally detached loner. Okay? They don't want closeness, not because of fear, but because solitude feels comfortable for them. CBT can help them build basic social skills if they want to change. Your goal as a therapist is not to make them social, it's to reduce the impairment and help them improve the quality of their life. Think of Bo Radley or Batman. They're isolated, they're detached, but they're functioning. Okay? And Bo Radley is from To Kill a Mockingbird. If you've seen that movie, it is on Netflix. Go ahead and give it a try. Or if you're into comics, Bruce Wayne, Batman. Okay? For differential diagnosis for this one, you want to distinguish ASD, autism spectrum disorder, because they have restricted interests and repetitive behaviors, from avoidant personality disorder, because they have social isolation because they fear rejection rather than a lack of desire. Their core belief is I'm better off alone. They are emotionally detached. Their affect is restricted. They have limited capacity for pleasure. They also have no desire for close relationships, and their indifference to praise or criticism. If you're going to give this particular client homework, think about gradual exposure to social contact. Help them start with one brief interaction per day and progressively increase the duration and the complexity. Always give them cognitive behavioral therapy to help them focus on their social skills and to help the behavioral activation. Okay, your goal is not to change their personality to make them social, but your goal is to reduce their functional impairment so they can enjoy their quality of life if they desire to change. Next, I want you to think about Luna Lovegood from Harry Potter when we are focused on schizotypal personality disorder, because she's very eccentric. So I want you to think of Luna, like the cousin that will meet, like, a cousin that have crystals and conspiracy boards, okay? And they have social anxiety that doesn't ease up, okay? It's like they believe in magic or coincidence or psychic energy, but they're not fully psychotic. So therapy for schizotypal personality disorder must be supportive and reality based. Sometimes you can, in some states, I know they let you prescribe medication, but if they're working with a medical doctor, like a psychiatrist, low dose antipsychotics can help them. Also check cultural context, ensure that it is spiritual and is not pathology, okay? They have, like, I don't know how to explain it without sounding confusing, because they have magical thinking, like odd beliefs, okay? And they have social anxiety, and it's from paranoid fears rather than negative self-judgment, and they speak in odd patterns, and they have unusual perceptual experiences. And for an assessment tool, always the personality inventory, the PID-5, the Million Clinical Multi-Axel Inventory, the SCID-5 for personality disorder, which is the structured clinical interview, okay? For this particular disorder, like I mentioned earlier, you want to exercise cultural sensitivity and avoid confrontational approaches that invalidate their cultural or their spiritual or religious belief, okay? Also, treatment approach for this particular disorder is supportive psychotherapy to help them focus on their social skills and reality testing. And as a homework, if you were to assign them homework, not in the first session, of course, right? You want to help them document their magical thoughts with subsequent reality. Cluster B, my favorite, is the drama cluster. They have big hearts, big feelings, big reactions. We have your antisocial, your borderline, your histrionic, and your narcissistic. I want you to remember the mnemonic, the memory aid: wild, wavy, wonderful, winning. Wild for antisocial features, wavy for borderline or instability, wonderful for everything is nice. For the histrionic presentation, I don't know if you ever saw the show from the 80s, 2227. It's on Hulu, I believe. And Jackie Robinson, the mother that was also on Sister with Tia and Tamara, she is classic histrionic personality disorder when I think about the character that she plays in 224 or 227, I forgot the name. And then winning for narcissistic grandiosity. So for this, think about the difference between passion and pathology is flexibility. Can they tone it down when it needs to be toned down? Okay, so for antisocial personality disorder, this is the rules don't apply to me mindset. When they are an adolescent, before the age of 15, it starts out as conduct disorder, and it continues into adulthood. The traits that they have is manipulation, deceit, impulsivity, lack of remorse. For this individual personality disorder, you have to use CBT or REBT to help them build their accountability and empathy if they are open to it. Think about the Joker or Dexter Morgan. Not really Dexter Morgan because of his moral code. It makes him a weird fit, but he also does feel like the rules don't apply to him, right? So when it comes to legally and ethics, document everything and safety come first. Also, I want to make you aware that antisocial personality disorder often show up in forensic or correctional settings, meaning that you'll frequently encounter them in the criminal justice system. They're either already there or they are at risk of being involved due to repeated violations of social rules and legal boundaries. But I also want to make you aware that not everyone with antisocial personality disorder commits crimes. Some of them use those same traits like charm, boldness, risk taking, and socially acceptable ways like sales, politics, or entrepreneurship. These are often the clients you'll meet in forensic or correctional settings, okay? So think probation, court order therapy, or reentry programs. You may want to help them with homework, with consequence mapping, to help them identify ripple effects of their behaviors, or maybe give them empathy journal exercising, okay? And if a medical doctor were to prescribe the medication, because the test may ask you what type of medication will be beneficial for this clients who have this, think of the SSRI class or mood stabilizers to help combat their impulsivity or aggression, okay? Borderline personality disorder, this disorder screams, don't leave me. They like to overstep their boundaries. Also, they have rapid mood swings, identity confusion, and unstable relationship. Their emotions shifts like the Florida weather, okay? I'm serious, okay? If you know, you know. In Florida, in the morning, it's cold. By noon, it's a thunderstorm. By the afternoon or the evening, it is tropical, like you in the Bahamas type weather. Think about borderline personality disorder in that way. So for therapy modality, DBT is the gold standard. Mindfulness, emotional regulation, distress tolerance, interpersonal effectiveness. If you ever watch Euphoria, this is Cassie. Okay, or Girl Interrupted, Susanna is the perfect character that fit this diagnosis. Always validate their feelings while keeping firm boundaries. This is a love with limits type of disorder, okay? And legally and ethically confidential limits apply during crisis. Document safety planning thoroughly. Okay, so histrionic personality disorder. This one is if I'm not admired or I'm not in the center of attention, I'm nothing. They shine the brightest in the spotlight and they have a crash out when they are ignored. If you were to have a client like this on your narrative or even in real life, you want to explore why their validation equals self-worth. I like to think about this disorder like the Marilyn Monroe persona, or the Sharpay Evans, or Gloria Delgado Pritchett. I'm gonna get into it more with Gloria Delgado, or Gabrielle Solis from the Desperate Housewives, or Nene Leakes, or Phaedra Parks from Real Housewife. These ladies serve main character energy. They're dramatic, they're stylish, they're emotional. But I also want you to remember, cultural expressiveness is not equal to pathology, because Latin warmth and Southern dramatics can be normal. And I'll go into that more when we talk about cultural within our slides. Also, for this particular disorder, the homework you would want to assign is to help them journal authentic versus their performed emotions. Okay? Give them insight-oriented psychotherapy to help them explore their underlying insecurities and why they seek attention. And what else am I missing for this order? Oh, for this disorder, which is super important, countertransference, because as a therapist, you may feel flattered or you may be manipulated, okay? So regular reflections are essential for you so you can maintain appropriate boundaries, okay? And another thing is a gender bias. Histrionic personality disorder has been overdiagnosed in women. So ensure your diagnosis is equal regardless of their gender or cultural expression norms. Narcissistic personality disorder, their core function is like, I'm special, others are lucky to know me. But underneath that confidence is a fragile self-esteem. So therapy with this particular client population will be to build empathy and to help them have a stable self-worth without applause. So I like Beauty and the Beast, Gaston, because he's singing about himself. No one smile as Gaston and whatever. I'm not really into Disney songs. I don't really like musicals. I just have to sit through them because of my children. But yes, Gaston's energy all the way. Or when I was a teenager, I used to watch The Sweet Life of Zack and Cody. Remember London Tipton? And she'd be like, yay me! Or London Tipton's really great, really great. That is the type of energy. Or they give you that Cardi B's Am I the Drama type energy. Also, my girl, Nene Leakes, she has that confident, not clinical line. She's self-assured, but she's also self-aware. So, for this particular group, keep firm boundaries, expect idealization and devaluation cycle, because their confidence celebrates themselves, and narcissism dismisses others. So you just kind of want to help them gauge how their need for excessive admiration and their sense of entitlement causes their distress or their impairment in their function, okay? Schema therapy is important for them. Also psychodynamic therapy and reflective journaling to help them gain a different or perspective of others. Also, Tony Stark from the Iron Man is a good character reference for you to remember. Cluster C flips the script because this is your anxiety driven, not attention driven folks. They want harmony so bad that they lose themselves. So remember, worried for avoidant personality traits, weeping for dependent personality disorder features, and wound tight for obsessive compulsive personality disorder. They usually have good insight and want help. So for this particular clusters, the prognosis is better. There are I want to say the right words because I don't want to offend a particular group of individuals. So for this particular disorder, they have insight into why they're distressed and they're motivated to change. They do respond well to CBT interventions, but also know that the different diagnoses, like anxiety-based patterns, they have a evasive fear that your therapy with them, a lot of their interpersonal belief will drive their behavioral choices, if that makes sense. So as a therapist for any individuals in these clusters, don't take anything personally. I'm going to say it again. Don't take anything personally, and be careful for transference or countertransference, especially with individuals with the obsessive compulsive personality disorder. Okay, so avoidant personality disorder, they have a core belief: if people get close, they'll reject me. They carve connection but fear humiliation. So with this group, you want to give them CBT and exposure therapy because it teaches them how to test their fears slowly. Think about Elsa from Frozen. She conceals, she doesn't feel. Medication may ease their anxiety, so therapy stick. And always separate this disorder from social anxiety disorder because this pattern runs deeper and touches identity. Dependent personality disorder is I cannot survive without others. They hand over their decisions, they avoid conflict, and they panic when they are alone. Your goal for therapy would be autonomy without abandoning them. So from that first session, you just help build rapport with them. If you were to assign homework, make one independent choice daily as your homework. Think about the older versions of Cinderella or Pam Beesly early in the series The Office. But as a therapist, you need to be careful not to become the new crutch. I remember having a question with an individual with dependent personality disorders, and one of the answers was not to pick the one where the therapist becomes the crutch to them, because your job is to empower individuals with this disorder, not to rescue them. And also watch for cultural norms, because family reliance is not equal to dysfunction. Obsessive compulsive personality disorder. This is if it's not perfect, it's worthless. They're rigid, rule-driven, and proud of it. They are egocentric. They're not distressed like OCD. So CBT and schema therapy help loosen that grip. Think about Monica Geller from Friends, or Sheldon Cooper from The Big Bang Theory. Okay, so your homework for them will be to leave a small task imperfect so they can feel the discomfort and they survive it. The assessment tools for personality disorder, I want you to think of the three big names and never forget them. The SCID-5 PD, the NCMHCE, and the PID-5. Those help confirm patterns across time, not just moods of the week. Also, don't be afraid to pair them with Beck inventories for comorbids and collateral reports, because clients rarely see their own patterns clearly. So these are the ones that you need to remember for all personality disorder. The assessment tools is the SCID-5, the structured clinical interview, the Million clinical multitask inventory, and the personality inventory for DSM-5, the PID-5, okay? Differential diagnosis. Personality disorders are egocentric. That means that the person says, this is just who I am. But something like OCD is ego-dystonic. That person says, I know it doesn't make sense, but I can't stop. Like OCD, the disorder, not the personality disorder, just to clarify. So on the exam, if the client thinks their behavior is totally fine, that's your cue that it's egocentric. It is a personality disorder, and it's likely a personality pattern, is not an anxiety disorder. So a quick way to remember this: centonic equals same side as the ego. Dystonic equals or mean distant from the ego. If it bothers them, it's dystonic. If it bothers everyone else, it's syntonic. So the exam loves tricking you here. Know the difference between borderline personality disorder versus bipolar 2. One is reactive, the other one is episodes. Know the difference between obsessive compulsive personality disorder versus OCD. One is egocentric, the other is ego-dyscentric. Know the difference between avoidant personality disorder versus social anxiety. One is pervasive, the other is situational. Schizotypal versus schizophrenia. One is odd versus the other is psychotic. I want you to think about the duration, the trigger, and the insight. If you see any one of these personality disorders, in your narratives, when you're testing, or even when you're studying or taking notes, think about the duration, how long they have it, what triggers them, and the insight that they have, because these are the key to let you know if it's egosyntonic or ego-dystonic. Now, personality disorders test your boundaries more than your theories, okay? I'm not even much going to hold you. You have to document like your license depend on it, because it does. So you need to know your TerraSoft laws, your duty to warn laws, okay? You also need to manage your countertransference, therapist. If you start feeling like the hero or the villain, pause, consult with your supervisor, okay? Know the difference between compassion and boundaries, because that is the difference between having ethical strength. And remember, your duty is to do no harm first. Also, match intensity to the risk when it comes to the different levels of care. Inpatient means it's an imminent danger, okay? Partial hospitalization is daily structure without lockdown. Intensive outpatient is skills and safety monitoring. Outpatient is long-term work. And for these type of personality disorder, DBT and intensive outpatient program is gold for individuals that have chronic self-harms. So you look at this letter, you want to step down as they grow in their stability. Never discharge them for being difficult. And come on, why would you? That's unethical. You know your ACA code of ethics. Don't be discharging your clients if they are difficult. Refer them out, but do not discharge them for being difficult. You don't want that ethical responsibility attached to your license. Therapists, when you are fully licensed or when you're in your provisional license, always think ethically. You represent not only your good name and your license, but you also represent the ACA, the NCC, the National Board of Counselors. Like, I need you guys to think long term. So when they're asking you things, because you know, we may think it's common sense, but sometimes common sense is not that common, and sometimes we find ourselves in compromising situations. That's why it's always imperative for us to go over our code of ethics. I'm sorry, I just went off a tangent right there. So culturally responsive practices, I want you to remember that culture defines what's normal. What's dramatic in Miami might be reserved in Minnesota. Always ask this therapy: is this behavior maladaptive or culturally expressive? And use your cultural formulation interview, your CFI, because you have to diagnose the patterns, not the people. For example, Sofia Vergara, when she's Gloria DeGlotto Pritchett in The Modern Family, she appears as vibrant, expressive, she's dramatic, she shows histrionic traits, but through a cultural lens, it's not pathology, but it's perfect to illustrate how personality and cultural intersect. When she's on Modern Family, she's attention-seeking, it's dramatic. She enters a room and instantly she gets the attention of everyone. She's loud, she's animated, her gestures, they're emotional, and it's storytelling. She's aware of her beauty and she uses it to influence others. She's like, Jay, don't I look sexy in this? Right? Emotionally, her emotions are expressive. And because her emotions are expressive, we like, her emotions are expressive, they're big, they're theatrical, they're tears, they're laughter, and they come within seconds, and she's rarely uncomfortable being noticed. She thrives in that spotlight. Her character shows classic histrionic charm, and that disarms people. However, why it wouldn't be considered a disorder? Because Gloria, in the show Modern Family, she genuinely cares for her family. She shows empathy and she sacrifices for them. So in real life, those traits, those clients will struggle to maintain those things consistently. So what I'm saying is, and let me get my thoughts together. What I'm saying is this. From a cultural context, her expressiveness reflects Latina cultural norms. Their warm, passion, high emotionality is not equal to pathology, if that makes sense. Okay? So her functional life in the show, she's adaptable, she holds relationships, and she maintains stability within her marriage, her family, and work. She gives histrionic energy, like the way the writers wrote her character, because she loves attention and expressive, and she's dramatic, but she's not disordered, if that makes sense. This is where cultural competence come in. So not every expressive woman of color is dramatic. Sometimes it's culture, charisma, and confidence, not a clinical pattern. And I say that so when we are in the field of therapy, and also when we're doing our exam, we are culturally aware of, okay, how does it affect this client? What is the clinical pattern that we are seeing? So, for these particular disorder in clusters A, B, and C, remember, if you're going to assign homework, it must fit the person, not the paper. So, cluster A, reality testing logs. Cluster B, DBT diary cards, empathy journal. Cluster C, exposure or autonomy practice. And remember, you have to praise effort over perfection, and their compliance will build slowly. So here is the clinical summary interventions. Know these, memorize them, and commit them to your memory. Write them down. Pause this page, write them down, or download the slides on the Buy Me a Coffee page, so you can have this, so you can remember each cluster, the example homework, the primary therapy, and the key focus. Okay? Also, personality disorder clients, they do struggle with homework completion, so you may want to start small and help them to build it gradually, and review it collaboratively with them, regardless if they were successful in completing it or not. Also, let's quiz it real quick. So, scenario 1, which cluster B disorder fits this statement, don't leave me? Is it histrionic, borderline, dependent personality, or avoidant personality disorder? If you put borderline, that is correct, because they have fear of abandonment, and that is the core feature of borderline personality disorder. Also, don't forget, for this particular disorder, boundaries are important. All right, scenario 2. A client presents with grandiose belief about their special abilities, odd speech patterns, and magical thinking, but they maintain a connection to reality. They have no history of full psychotic episode. Which diagnosis is most appropriate? Schizophrenia, schizoid personality, schizotypal personality, or delusional disorder? Please don't put schizophrenia, because the question tells you that no history of full psychotic episodes. It tells you that. Go back to the previous slide where I talked about schizotypal personality. Speaking of schizotypal personality, A is the correct answer, because you have to differentiate the absence of a full psychotic episode. And remember, schizotypal personality disorder involves odd beliefs and perceptual experiences. So it's not like schizophrenia or delusional disorder, for example. So anchor your answer in the core belief of each disorder. That is the blueprint. And these are many scenarios. We can go through them if you like. So pause this video, read the questions. All right, scenario 1. You have a client that storms out of session after you mention limits, right? You told them you need to end on time because of your next appointment. They get a flustered face. They say you clearly don't care about me. They stand up abruptly and they storm out of your office. They slam your door. What is the most likely diagnosis? If you said borderline personality disorder, that is correct. The reason being because they have intense emotional reaction to a perceived abandonment, i.e., you telling them that you must end on time. They have all or nothing thinking. They might think you do not care. That's what they said. And they have impulsive behavior. They're storming out. Those are hallmarks of borderline personality disorder, because their reaction is disproportionate to the trigger and involves splitting. So you went from the idealized therapist to the uncaring villain instantly. So for this particular individual or this disorder, if you have something that happens like that, document the incidents, follow up with a call or an email, reiterate your availability and your boundaries, and process the incident in the next session if they return, and avoid punitive responses while maintaining consistent boundaries. All right, let's talk about scenario 2. During intake, the client speaks in a monotone voice, makes minimal eye contact, and shows no emotional expression, even when discussing potentially distressing topic. When asked about relationship, they report having no close friends and state they prefer activities like reading puzzles and solo video games. They report no distress about this pattern. What is the most likely diagnosis? Take a minute. All right, got it. The correct answer is schizoid personality disorder, because they have a clear emotional detachment. Their affect is flat, and they lack close relationships. They prefer solitary activities, and they lack distress about social isolation, and they characterize and that's key character insight for schizoid personality disorder. This one is different from avoidant personality disorder because they have an absence of desire for a relationship. So this client genuinely prefers being alone rather than fearing rejection. And your response as a clinician is to respect their preferences, and you should have goals that focus where the pattern causes the actual impairment, like at work, for example, rather than trying to change them or their social orientation. Let's do scenario 3. In a group therapy setting, the client becomes tearful and says, "Nobody cares about my problems." When this discussion moves to another group member, in individual sessions, they dress provocatively, frequently compliment your appearance, and become dramatic when you don't respond to their texts between sessions. They describe their life as a movie. What is the most likely diagnosis? Histrionic personality disorder, because they have an excessive need for attention. They're dramatic. They use physical appearance to draw attention. They are theatrical, and they have discomfort when they're not the center of attention, which is classic histrionic personality disorder features. Okay. For this particular diagnosis, you want to maintain professionalism and boundaries, and you need to focus their therapy on helping them to express themselves and their emotions in an authentic way. And you're going to teach them cognitive techniques to address their constant need for admiration. Okay, so this is your homework assignment, okay? I want you to grab a show. Euphoria, Modern Family, Batman, Real Housewives, any of the franchises, Desperate Housewives, and I want you to spot the traits. Write the character, the observed behavior, and which cluster it fits. I want you to do that because it's going to help you build your diagnostic intuition while reminding you that these are patterns, not punchlines. And also, personality disorders grow from survival. They were strategies that worked once, but it stopped serving them. So every difficult client, I want you to keep in mind that they was once a child that was adapting to chaos. Healing starts with empathy, not judgment. Do not judge them. It's not who they are, it's what they learn to be. And as therapists, our job is to teach them new learning. You have to teach them safety, trust, regulation. I want you to put into perspective, you have to see the human before the diagnosis always. If this video helped you, please drop a comment and tell me which personality disorder character is your favorite and why. I do read the comments and I do respond to the comments. And please don't forget to like, share, subscribe, and also that's what helps our channel grow. Share with your study groups, Reddit, and that helps me to keep creating more resources for you. Like I mentioned time and time again, the PowerPoint slides are available on Buy Me a Coffee for a small donation if you fancy. It's not a requirement, it's totally optional, but it does help support this channel and the bigger vision behind it. You can also check out my mini narratives on personality disorders on Gumroad. These are designed to help you practice basic recall so you won't leave any questions on the table for your actual test. And once you got that foundation, we can move on to my full clinical method narratives. Those are going to sharpen your critical thinking and treatment planning skills. I'm not chasing money, I'm chasing purpose. My goal is to let my talent make room for me and create something meaningful beyond corporate life. So if you believe in this mission, share it with someone who's studying too, and help me help others pass with purpose. Until next time, guys, I want you guys to study with intention. May understanding come easy for you. May your anxiety fade, and may your purpose be strengthened. And amen. Many blessings to you.